welcome to
Tonight, Dr. Sheldon Blau is a clinical professor at State University of New York at Stony Brook. Dr. Blau has written 8 books and over 50 articles on his specialty. He has also appeared on national TV on such shows as Oprah Winfrey, Today Show, and Joan Rivers Show. I would like everybody to welcome Dr. Blau, who will be speaking tonight on osteoporosis.
Thank you for your kind words, Kathy. I'm happy I brought my wife to hear them. If I would have known you were going to read everything I gave you, I would have brought my 7-year-old granddaughter. Actually, she gave me instructions for this talk. She said, Grandpa, wear a tie, don't be funny, and don't be smart. She said, be your usual self. So I won't be funny and I won't be smart. This evening I'm going to discuss osteoporosis, a subject that, as I look out in the audience, many of you have. As a matter of fact, if you don't have it, if you're lucky enough, you probably will develop it in time. And I say lucky enough because you really have to live long enough or take certain medications to develop osteoarthritis. Do any of my friends, by the way, first of all, I want to welcome my friends who have been referring physicians now for some 30 or 40 years. Thank them for the trust they've had in me. But I want to ask them, because I always ask embarrassing questions. Osteoporosis is a new disease. It's a new disease of the last 100 years. At the turn of the century, the turn of, not this past century, but the century before, osteoporosis was virtually unheard of. Any of you guys or ladies want to guess why that's so? Didn't live long enough, absolutely. Heard from Dr. Enti, who was around at the turn of this. That's right, they didn't have pediatrics, doctor, right. Exactly. So you really have to live long enough to develop osteoporosis, aside from some other conditions that I'll mention to you tonight. Let me first start with a great definition of osteoporosis. This is can you see that? Absolutely. No, you can't. You better, you go sit over there. Yeah, because you cannot see that, and I. Not miss a word. No, but I'm going to ask you questions. So you go sit over there at least. You can't sit behind.
Would you not ask me questions?
If you promise to sit over there, I won't ask you a question. This is a systemic skeletal disease characterized by low bone mass, which we'll get to soon, and micro-architectural deterioration of bone tissue, with an increase in fragility and susceptibility to fracture. The operative word here is fracture. The reason that we treat osteoporosis is because these patients fracture. Okay. There are 25 million people in this country who have osteoporosis. 80% of them are women. And if you are over the age of 50, and I don't see too many of you here who are over the age of 50, the likelihood of you having a fracture runs some 40%, which is really interesting. By the way, anybody in the room had a fracture themselves? Oh. A toe counts. If you kick, you can get a fracture, right? Okay. All right. Now, the incidence of osteoporotic fracture, this is to simply show you that it's most common in vertebrae, second in hips, and third in the wrist. I used to think, and by the way, when I say used to, this was as recently as a month ago, that the vertebral fractures were only painful. As I'm going to show you soon, they're more than painful. They're actually lethal. Hip fractures, I went to medical school in 1957. Hip pinning was begun in the 40s. Prior to hip pinning, if you had a fractured hip, the mortality was 100%. And the reason for this is these patients were put into bed and they virtually all died of pneumonia. Even now, with hip pinning, there's a significant mortality to hip fractures. As a result of this, one gets obviously a diminished quality of life and significant morbidity and mortality with all sorts of osteoporotic changes, whether it be the spine or the hip. And there's an economic burden that I'll briefly mention. The economic burden consists of some $25 billion a year spent on osteoporosis. Now, as far, you know, I panicked for a moment. You went in front of that thing and the lights went out and I became aphasic. All right. Vertebral fractures, 500,000 a year, and one of the big problems is loss of height, the typical dowager's hump, and there's one more thing that patients with vertebral fractures develop. They develop a pot belly with enlargement of their waist. Now, when you see someone who has osteoporosis, you'll notice that that indeed is the case. Again, as to hip fractures, again, 250,000 a year, which I'm sure the orthopedists are happy to hear. More than 20% excess of mortality within a year of the hip fracture. And 50% fully never recover from a fractured pinned hip. Again, the problems are hospitalization, rehabilitation, and long-term care. Any of you who have relatives who have fractured a hip know about this. Now, this is a picture of osteoporosis. I show you normal bone on the right. You know, I forgot to take my little pointer. I show you these normal trabeculae on the right, and you'll notice that on the left, all of the trabeculae are gone. Now, as I was running through these slides the other day, by the way, just an aside, as I ran through the slides, the entire presentation took 3.5 hours. So I try to cut it down, but I'm not sure that I did that. In any event, as I was looking at these slides, it occurred to me that the osteoporotic bone really looks very much like mad cow disease of the brain. It really does. I mean, you get big holes, and you get big holes in the brain. Now, no one has ever said that osteoporosis was due to, you know, the virus that causes mad cow disease. If that ever happens, you'll know that you heard it here first. Okay, here is what the problem is in osteoporosis. There are two types of cells in bone, osteoclasts that resorb bone, osteoblasts that lay down bone. If resorption is greater than the laying down of bone, then you get osteoporosis. It's a very simple biochemical phenomenon. This is probably the most important slide that I want to show you. I want to show you what happens to bone growth through the decades. And for the pediatricians who are in the room, this slide is terribly important because during the periods of active growth between the ages of 15, the menarche, and roughly 25 to 30, you'll notice that bone mass is maximum at about 25 or 30. You can direct this curve up. You can direct this curve up by physical activity. If you take a child, an adolescent, and put them in bed, or make them amenorrheic, or give them, as Betty had someone who worked for her who was an anorectic, or give them a lactase deficiency, or give them anything that interferes with calcium absorption, you can drop that curve down. You'll notice that at menopause, the curve goes down. And all of you menopausal women will know that that's so. The curve for bone drops at the menopause and continues to go. So what I said at the opening of this talk was that if you live long enough, you'll be lucky enough to develop osteoporosis. And notice that as you get down here, you're just about where you were when you had your menarche, and you've lost significant amounts of bone. You are as good as you were between the ages of 15 and 25. The statement you're getting older and getting better is not true. You're getting older and you're getting osteoporotic. Now, there are some things, older, I said. Okay. As a romantic, right? There are some things that you can do about this, and we'll mention that soon. So, actually, this slide has philosophical implications. I mean, you are now what you were between the ages of 15 and 30. Stop and think about that. If you were a nail biter then, you're probably a nail biter now. If you were a slut then, you're a slut now. Whatever you were then, you are now. And again, there's continued bone loss here. Okay, what are the risk factors? My granddaughter gave you a message. Tell them not to be funny. Okay. Risk factors, postmenopausal status, and an early menopause. If you've had an early menopause before the age of 45, you're going to have osteoporosis. If you're white or Asian, way to go, Marge, way to go, Shamika, okay? Way to go, Lorette, okay? If you are black, the likelihood of having osteoporosis is much less. I had a black lady in the office, some of the women who work for me will remember, and she was a smoker. She was a couch potato. She weighed about 250 pounds, and I said, you may have osteoporosis, and she said, I don't have osteoporosis because I'm black. I said, well, let's do the bone density anyway. Right? We did the bone density perfectly normal. She said, see, I don't have bone density. So black, she was right. And certainly a thin, small build. If you're a skinny little lady, and the last patient I saw in the office before coming here was 87 pounds and 5'2". And if you have a family history of osteoporosis, then the likelihood of you developing osteoporosis is very high. And certainly, as everybody knows in this room, certain medications, particularly steroids and other medications, will cause osteoporosis. But we'll get to that soon. Okay, I got it. Now, certainly I'm not going to go into this in length, but all of the doctors in this room, as well as their guests, know that there are many different reasons that you may have osteoporosis aside from postmenopausal or steroids. The commonest disorder that we're concerned with in the office in the differential diagnosis of osteoporosis is myeloma. And that's why SED rates are so important. As you all know, a SED rate is normal in postmenopausal osteoporosis, but very high, and one can easily differentiate the two. Well, not so easily, but often differentiate the two. The other diseases that cause osteoporosis are well known to most of you. Risk factors. Family history, I said, a previous fracture, and a propensity to fall. You know, that's a terribly important line, a propensity to fall, because the propensity to fall can certainly be obviated by a variety of activities, all physical. And that's why I think that little old ladies who have a propensity to fall should be sent for physiatry to people like Nahid in our office, who will strengthen them. As a matter of fact, not only will they strengthen them, but they will give them exercises so that falling, you do exercise with osteoporosis not to build bone, but to prevent falling. As all of you know, there are patients who are frail, they're brought in by their relatives. These are the ones who not only are you afraid they're going to fall, you're afraid they're going to fall in your parking lot on the way out. These are the ones who really require physical therapy the most. And the older and the weaker you are, the more you need physical therapy. And certain medications, as we'll see, will cause osteoporosis. Okay, the number one risk factor for osteoporosis is a low bone density. I've often been asked if a low bone density is a sine qua non for osteoporosis, and it really is. In other words, if you have a low bone density, you have osteoporosis by definition, and I'll tell you how the numbers work in a few minutes. So the low bone mass is the single most accurate predictor of increased fracture risk. Now, when I was in medical school, when I was an intern, when I was a resident, when I was a fellow, we could not measure bone mass. There was no technology that would enable you to measure it. If you took an x-ray of the spine and it looked kind of pale and washed out, you said, well, the patient has osteoporosis. But the facts of the matter are that by the time you see it on x-ray, you've lost 30% of your bone. So x-rays are of no value in following the course. Bone densitometry is, and we'll talk about that soon. A bone densitometer measures the amount of osteoporosis you have. If you're just one standard deviation away from normal, you have an almost 2-time risk of fracture. If it occurs in the hip, it's almost 3 times the risk of fracture. So again, I say to you that every woman in this room who's over the age of 50 or postmenopausal should have a bone density. The bone density helps, first of all, to confirm the diagnosis. It assesses the severity, and it tells you sort of how fast you're losing bone. So that if your T-score, and I'll get into this in a moment, is minus 2.5, and the next year it's minus 3.5, you've worsened significantly. As a matter of fact, the only way you can really monitor therapy effectively is by doing serial bone densities. The indications for doing a bone density are very simple, all of these, namely for people concerned about it. As a matter of fact, we had, I'm proud to tell you that we had the first DEXA machine probably in Long Island. We had it some 15 years ago before anybody had it. When we did a DEXA bone density and sent the bill to Medicare, Medicare would send the patient a letter saying, this is an experimental procedure and we're not going to pay for it. Now that, of course, would make patients bananas. I mean, they would come in and say, what kind of an experimental procedure, did you do? I once had a patient who, following the bone density and following the letter and following the husband bringing in the letter, the woman got a stroke. And he was convinced that she had a stroke as a result of the bone density. So bone density is, now people are walking in. They're coming in off the street. Will you do a bone density? But 15 years ago, that was not the case. 15 years ago, my partner told me we never should have gotten the bone density machine. I won't tell you which partner it is. Maybe you'll figure it out. Okay. You see, women who work in my office know which one it is. There are different ways to measure bone density. This is for, by the way, do any of you have a bone densitometer? Oh, good. Then I can say anything. Do any of you have a bone densitometry? I know you don't have a bone densitometry. Walter, do you have a, no, you wouldn't have one. I'm happy that you don't have it, then I can say whatever I want. But the fact of the matter is that the DEXA, DXA, is the most accurate, most reliable way of measuring it. There are other ways. There's a quantitative CAT scan. Who do you use a quantitative CAT scan on? That's the question is open for grabs, guys. You use a quantitative CAT scan on someone who can't fit into your machine. Margie, how big do you have to be to get a DEXA? 250. If you're above 250, you can't fit in the machine. You got to send out for a quantitative CAT scan. Now, what's the disadvantage of a quantitative CAT scan? The disadvantage is a tremendous amount of radiation, whereas with a DEXA, there's very little radiation. The other procedures, namely the heel and forearm and the calcaneus, are primarily chiropractic podiatry instruments and should not be used. Radiographic absorptiometry of the hand, you take an x-ray of the hand and next to it you put a piece of aluminum and you mail it off to a company who sends you back a letter with a number on it. It's the poor man's way to do bone densities. The best way, as you will see, is the DEXA. Now, some of you will hear of biochemical methods, NTZ determinations they're called, that are put out by pharmaceutical companies to establish bone turnover. I'll simply tell you that we don't use them and we don't think that they're of any value. What you do is you give the patient something to take and you measure the urine excretion of it, and it's an indirect measure of bone turnover. In our experience, we just never use it. Okay, this is a picture of the DEXA, and that's Dr. Sullivan in drag standing by the machine. Our machine looks just like that, except the room is not so clean, and we have Margie's pictures on the wall, right? But that's what the DEXA looks like. The machine is $80,000. A bone density, you bill $350, you get back $125, so the PE is about 600 to 1. That's if you only do one a year. Okay. Of course, if you do one a day, then perhaps it makes financial sense. Of course, if you do one a day on the same patient, then a big fat man with a white shirt comes with a badge, and he says, let's talk about this. So you certainly don't want that. This is the DEXA. Now, I'm showing you what the DEXA looks like, not to go through these numbers, but to simply tell you that I could teach anyone here in less than 5 minutes how to read these. But most people don't know how to read them, and we're happy. We're happy that they don't know how to read it. The thing that you're interested in is one number, the T-score. The Z-score is of no importance. It's of no importance for the things that we're going to talk about. This is the RA, the radiographic absorptiometry. There's the piece of aluminum. You take a picture of the patient's hands here, and you mail them away literally to a company who will then put this through a quantitative absorptiometry machine and send you back a number. It works, and it works well. It's just, it's cumbersome, it's a pain in the neck to mail it back. You have to be sure it's the same kind of aluminum. I mean, there are all sorts of drawbacks to that. Okay, now, as I told you before, but showing you a little differently, the peak bone mass for a young adult woman, you happen to know that, Walter? No. For a young adult woman is between the ages of 15 and 25. So that's when bone mass is really strongest. This is a lady who you can see her name is Linda Carson. She's 50 years of age. She was 50 years of age when that was taken. This was Linda Carson at age 75. And just in case you missed the first picture, this is Linda Carson then and now. Now, you know what the frightening thing of this picture is? And not, of course, how she looks, because we could all live with that. The frightening thing is that I was alive when they took the one on the left and the one on the right. And if this is what she looks like to me, I wonder what I look like to her. This is what osteoporosis does to you. And you will notice the change in physical appearance. You will notice the kyphosis, the lump, the dowager's hump. And you will notice the pot belly. They get a pot belly, and I'll show you why and how. Here is what happens with osteoporosis. as you develop this forward bending, this kyphosis, your belly becomes protuberant and your clothing size increases, which means that you really have a problem in buying clothing. Now, just having the pot belly without the kyphosis doesn't count because that's something else. That's exogenous obesity. So this is what happens serially with osteoporosis to your spine and to your abdomen. Okay. Now we're going to speak about therapy. Now let's talk about conventional therapy. Let's first talk about calcium. Most patients do not know what they're doing when they take calcium. Now let me tell you why. I think some of you are familiar with Jane Brody, who writes the science article in the New York Times. By the way, Jane Brody is a classic personality type, physical habitus type for osteoporosis. She's about 4'10", and she weighs about 90 pounds. Jane Brody wrote an article in the New York Times some years ago about different calcium preparations and the fact that cheaper is usually worse. In other words, calcium preparations are mostly made up of calcium carbonate. Those are stones. Those are literally stones. Most calcium carbonate that you take goes into your mouth and comes out in your stool totally unaffected. By the way, if you take calcium with orange juice, you convert the calcium carbonate to calcium chloride. That becomes even harder. So Jane showed that there was no effect of oral calcium unless the following situation occurred. If you take a calcium tablet, and any of you women who are taking calcium now would do it when you go home, take a calcium tablet, put it in a half a glass of vinegar, and wait a half hour, and then come and stir it. The vinegar should be totally white, and the pill should be totally dissolved. If it's anything less than that, your calcium is not being absorbed, and you're really not taking calcium. Now, I can't begin to tell you how often this happens. As a result of that, we end up using only one preparation as a calcium source, not because this is the only preparation that works, but it's the only one I can remember that works. So we prescribe Oscal to everybody. I don't know if Oscal is made by PG or not, but we use Oscal. In addition to that, it's important to remember that giving calcium, and by the way, we give vitamin D all the time. Everybody gets vitamin D. Everybody gets vitamin D, and we do this because 40% of patients who are in any office are vitamin D deficient. So we give Oscal with vitamin D. And it's important to recognize that vitamin D and calcium does not prevent fracturing of the bones. So if you just take someone who has osteoporosis, has a standard deviation that's abnormal, give them calcium and vitamin D, and then repeat it a year later, I guarantee it'll be worse. So you have to give something else. Now, that something else, okay. That something else is any of these. As a matter of fact, this is everything that one uses for osteoporosis. We use estrogens and progesterone. We use something called calcitonin. And we use a group of drugs called bisphosphonates. The examples of the bisphosphonates are Didronil, Fosamax, and Actonel. Now, let's talk for a moment about each of these and which you should use. By the way, I'll throw in very quickly the SERMs, S-E-R-Ms, the serum estrogen receptor modifiers. There are many of us who don't believe that the SERMs are worth giving. We have already had probably a half a dozen patients who have had problems with clotting with SERMs. If you're taking a SERM, as a matter of fact, we have one in the office. We have a lady who clotted her entire inferior vena cava. Phlebitis is common. DVTs are common. The efficacy of SERMs has yet to be shown to be as effective as Actonel, for instance. All right, so let's get first of all to the estrogen replacement therapy. Probably many of you in the room are taking them. Estrogens are great drugs for the prevention of osteoporosis. They really do prevent it. The problem is that, they do all of these. They reduce the risk of fracture. They prevent bone loss. The problem with estrogen, as you all know, is, oh, by the way, here, this shows you that estrogen with calcium really improves your bone density. This one shows you that the problem with estrogen is this. The problem is there's an increased risk of endometrial cancer, and the big problem is breast cancer. Now, we've been saying that estrogen may increase the incidence of breast cancer for many years. Within the last few months, you know that it hit the Times as a result of the New England Journal of Medicine. which said that patients taking estrogen replacement had a twofold increase in the incidence of breast cancer. Now, if women in Long Island have a 1 in 9 incidence of breast cancer, and then you double that, you're down to 1 in 4. So that's one of the main reasons for not taking estrogen. By the way, one of the other good parts of estrogen is that estrogen can reduce the risk of coronary heart disease. Years ago, again back to my medical school days, we used estrogen in men who are high risk for coronary heart disease in an attempt to prevent its occurrence. I never took it, and I got heart disease anyway. This is calcitonin. Calcitonin, as you know, is secreted by a gland that's near the thyroid. It's administered intranasally, so people are sniffing all the time. The miacalcin is the preparation. By the way, there's only one preparation. It's called miacalcin. Miacalcin is okay, but it's not great. As a matter of fact, it's never a first-line drug. We only use miacalcin when you can't take one of the others, residronate or something else. So miacalcin is okay. Now, this, as it says here, increases your lumbar spine but does nothing for hip fractures. In other words, patients who would take miacalcin do not prevent their hip fractures from occurring. Okay, what the problems with taking a nasal spray is that everybody walks around with crusty noses. You could tell the patients who are taking miacalcin from the cocaine users bleed, and these just develop crusty noses. That was just my attempt at humor. All right, now, what about the bisphosphonates? Newest classes of drugs for treating osteoporosis. These are potent inhibitors of bone resorption. Now, let me say the very first bisphosphonate that came on the market was Didronil. All of the drugs, all of the bisphosphonates, the three of them, have in common the fact that they have tremendously long half-lives. Now, you all remember that the half-lives of many drugs are measured in hours, some in days. The half-life of these drugs runs years. So once you give them, you've given them forever. Therefore, at the present time, now this may change in the future, one would not wish to give the bisphosphonates, any of them, to a young lady who wants to who is going to get pregnant in the future at any time, because it's got a 10-year half-life. So taking a 25-year-old osteoporotic malabsorber, okay, and giving her Fosamax may doom that child. I mention this to you in case you have any premenopausal women who are capable of becoming pregnant on these drugs. They shouldn't be. What happens, what are the other similarities that they have? Well, they really have low oral bioavailability. That means they're absorbed very minimally, only a few percent. In other words, you give Pen-V, 100% of it is absorbed. You give Cipro, 80% of it is absorbed. Here, you can only absorb less than 5%. But the less than 5% really is important. The side effects are primarily, but not exclusively, GI, and musculoskeletal, bubbles in the neck, Mal. Okay, Dr. Goldner told me before we started, or was it you who told me about bubbles in the neck? No, I'm sorry. What are you smiling? It wasn't you. Dr. Boskin told me about a patient who said that they had bubbles in their neck. That's one of the side effects. You get musculoskeletal aches and pains. Okay, the newest kid on the block is a drug called residronate. It just came out probably about a year ago. This is its chemical structure for any of you who are interested in that sort of thing. And here are some of the things it does. And here are some of the things that it's been shown to do. Not that they hope it's going to do, that it really does. First of all, it's used for the treatment of osteoporosis for postmenopausal women. It increases bone density. As I said to you before, if you've got a bad bone density, this is the way to go. It reduces the incidence of vertebral fracture. Very important. And it does a couple of other things. It may be considered, and I don't think that you've gotten approval yet for, yeah, I think you did. We use this in patients who are, let's say, menopausal-ish who have abnormal bone densities, but it's not the full-blown -2.5 standard deviations that sets it aside as osteoporosis. In other words, the T-score can be anywhere from 0, which is normal, perhaps sometimes even above normal, in women who were very active and physically active when they were young, to, of course, very, very low. A T-score of minus anything to -2.5 is called osteopenia. Okay? Below 2.5, it's full-blown osteoporosis. So Actonel can be used in patients who are, if you will, Erev osteoporotic. Erev meaning the night before. I explained that. I didn't think you knew what the Jewish word meant. Okay. Now, this is glucocorticoid-induced osteoporosis. Now, we meaning the rheumatologists, are responsible for making this, because whenever you treat patients with steroids, particularly in doses above 7.5 milligrams, you're going to get osteoporosis. I might add parenthetically that Medicare will approve a bone density every 2 years. Is that right, Margie? Every 2 years? Okay. If you're on steroids, they'll approve it every 6 months. Now, the reason for that is they recognize in their infinite wisdom that osteoporosis can be caused very rapidly by steroids, and one often asks the question of how quickly it can be caused. And I can tell you that I've seen osteoporotic vertebral collapse in a week in elderly people who are taking large doses of steroids. In speaking to, I just heard a conference on went to a conference on anticardiolipins, and as some of you know, heparin causes osteoporosis commonly. I asked the speaker how quickly heparin will cause osteoporosis in a otherwise healthy woman, and the answer was within a week. So heparin causes osteoporosis. If you are going to give somebody a drug that can cause osteoporosis, such as heparin, such as steroids, such as Dilantin, such as a variety of others, then consider monitoring more often. Okay, here is Actonel. Here is the comparison between Actonel and placebo, and you'll notice significant reductions in this country and abroad. And you'll notice that when you do vertebral evaluations, that certainly between control and residronate beats the control significantly. And you really have to demonstrate this data to the FDA before they'll approve it. This is a slide to show you that over a 3-year period it does the same thing. In other words, it's not just a 1-year phenomenon. When measured as far as 3 years, it still significantly reduces the incidence of non-vertebral fractures, meaning wrist and hip. Okay, when you study the lumbar spine, after 3 years, you see this change between controls and between the drug. So residronate works. You'll notice that once again, the lumbar spine in early postmenopausal women, now remember, this is the control, which means that this curve parallels the decrease in bone mass curve that I've shown you twice before, namely what happens in time. Over time, everybody's bone density decreases. Everybody's bone density who's postmenopausal. Here I'm showing you that residronate reverses this. Okay, what about steroids? The question has always been asked, what's the safe dose of steroid? The safe dose of steroid is probably less than 7.5 milligrams of prednisone or its equivalent. We strive for that dose. Patients who are taking 10, we try to slowly reduce them. We feel that 7.5 milligrams is probably safe. Certainly if you take less, it's probably better, but many patients can't tolerate a smaller dose. In glucocorticoid-induced osteoporosis, in steroid osteoporosis, it is unlike postmenopausal osteoporosis in that it occurs regardless of your age or your sex. It occurs in the following conditions that you use steroids for, namely asthma, chronic obstructive pulmonary disease, rheumatoid arthritis, bowel disease, and lupus. And it says here that it can occur in as little as 3 months. It can occur faster than that. If you have underlying osteoporosis, it will occur much faster than that. And 50% of patients taking 7.5 milligrams of prednisone or more. Now remember, this is for a whole variety of illnesses. I mean, if you have your asthmatic who every time they wheeze, you say take a little prednisone. By the way, this counts not only orally, but by inhaler. The Salucortef enemas, they all count. Even the ointments, even topical heavy-dose steroid ointments can cause osteoporosis and avascular necrosis. Okay. Once again, if you administer these drugs, these bisphosphonates, particularly in this one, residronate, you'll notice that everything gets better, and everything gets better, and everything stays better. So residronate works. It's much better than placebo. And in summary, what happens is that Actonel, vertebral fracture risk is reduced at 1 year up to 65% on postmenopausal osteoporosis, and it's reduced to 70% in glucocorticoid-induced osteoporosis. And there are sustained effects over 3 years. Non-vertebral fracture rate is reduced in postmenopausal osteoporosis, and there's increase in bone mineral density in both of these conditions as early as 3 months in the spine. Now, because I know that you all have memorized it, wait a minute, I'm not going to get to the memorization. I want to get you to the GI part. One of the big side effects of Fosamax and of Actonel is, in quotes, GI intolerability. In other words, you give it to a patient and they say, I have agita. And there have been, of course, reports, particularly with Fosamax, of esophageal rupture with Fosamax. Now, let me tell you how this, and by the way, and every patient has read this. Every patient comes and says, I don't want to burn my esophagus out. This has occurred primarily, but not exclusively, in nursing home patients. In other words, patients are in bed, they're propped up, somebody throws a pill down their throat, and they lie down again, and the pill lodges in the esophagus, resulting in esophageal irritation and esophageal perforation. So if you want to have a better mousetrap, what you have to do is you have to make a drug that has less GI distress. In this study, all patients, whether they're on NSAIDs or aspirin or really had agita for any reason at all, were put on residronate, and you'll notice that there was a little difference between the controls and the test subjects. What we do in our practice is if a patient complains of GI distress due to Fosamax, we switch them to Actonel. We've had great success in doing that. Okay, you know, this slide is really interesting because if you look at it, the most fascinating part is the bars on the left where you see patients, so-called normal patients, on placebo who are endoscoped. You would expect that you would expect if none of us are taking any medication that causes GI ulceration, that we would have normal esophagoscopy and normal gastroscopy. That's not true. Only 60% of us will have normal. The other 40% will have esophageal inflammation, esophageal erosion, and esophageal ulceration. So there's an enormous incidence of GI disease that is asymptomatic. I myself personally learned that I just learned this 2 months ago. I spoke to a physician who had called me, and I was coughing. And he said, I hear you coughing. I said, thank you, that's a good diagnosis. He said, do you have GERD? So I said, GERD is gastroesophageal reflux disease. I said, it so happens that I do. How did you know that? And he gave me this statistic that I recently found out was absolutely correct. The commonest cause of a cough in an adult is GERD. Interesting. So there are a lot of people here and in the world who have asymptomatic GI disease. Here, when you do gastroscopies on them, you notice that probably 40% have something wrong with them. Now, the real final proof as to which is a better mousetrap depends on head-to-head studies. In other words, take studies and measure residronate with its competitor, namely Fosamax. And they did this. Head-to-head studies demonstrate the incidence of gastric ulcers is up to 70% less with residronate. So I think you should know this. And Mel Boskin asked me before, what you use with a gastric ulcer. Well, you use a whole lot of things, but I think residronate might be a better choice. Now, having said that, I'm going to show you a couple of cases and ask you what to do about them. This is your time. You'll discuss the cases, you'll tell them what to do and why you want to do it. All right, first of all, let's take the first, a 55-year-old woman, 3 years postmenopausal, comes in and says, I want a bone mass test. She's unwilling to take hormone therapy because her aunt had a breast cancer. She doesn't smoke, she's active, and she's a milk drinker. Physical exam is normal, but her bone density is minus 2.7. Her T-score is minus 2.7. Now, I said to you, if you're more than minus 2.5, you've got osteoporosis. This lady has osteoporosis despite the fact that she's physical, despite the fact that she's a milk drinker, despite the fact that she's all of these things. And this lady should be on a bisphosphonate, probably Actonel. Now, let's do another one. Okay, a 60-year-old lady, 20 years postmenopausal. Thyroid hormone therapy since age 30. That's why I asked you. I won't repeat your name because it's not nice, but you know who you are. If you're this patient, you know who you are. Smokes 1 pack of cigarettes per day. Were you a smoker, Marilyn? Never. You were a smoker, really. This is you. Physician recommends a bone density. Did I recommend a bone density on you? Yes. Good for me. But the bone density, listen to this, despite the fact that she's 60, and someday you will be 60, Marilyn, despite the fact that she's taking thyroid all of her life, and despite the fact that she was a smoker, the bone density is only minus 0.7. This lady, despite the risk factors, does not need any of the bisphosphonates. Calcium supplementation and vitamin D are fine. Okay, let's do 1 or 2 more, and then our steaks will be ready. But we're not going to do it if I can. Okay. All right, now, another case. This is a couch potato, postmenopausal, 65-year-old lady. She has chronic obstructive pulmonary disease. She's on prednisone for 12 years. She has a history of rib fractures with coughing. If we have time, let me tell you about rib fractures. And her bone density is minus 3.2. Well, this lady obviously needs something. She needs medication. This lady is going to get worse, and she's going to fracture more ribs. I do have a moment, and I'll tell you about rib fractures. I have seen on several occasions physicians fracturing ribs of patients inadvertently by physical examination. By examining their abdomens and they're severely osteoporotic, they've fractured ribs. As a matter of fact, I had a patient tell me that they went to see an expert in New York City at Mount Sinai. And he said, and guess what he did to my wife, Dr. Blau? I said, well, he said he fractured her ribs by examining her. So if somebody is really down in the minus 3s, you better watch out. Okay, now, I think this is the last one. This is a little old lady. This is the lady I saw today. The very last lady, remember, in the office who came in with the daughter? This is her. This is a lady who's 5'2". By the way, this example is 100 pounds. She was only 87 pounds, okay? She walks with a cane following a hip fracture. She hadn't fractured her hip yet. But I want to tell you something. When her daughter took her under the arm and brought her in, and I finished examining her, I wanted to help her out to the car because I didn't want her to fall. She has a history of falling while on hypertensive therapy. It's exactly what she had. And her bone density is minus 2.9. Well, this lady needs Actonel and calcium supplementation. And also, this patient needs Dr. Vanderwall to increase the strength in her hips. Now, let me just close by saying one last thing about hip fractures, because for those of you who see patients like this may come in handy. It's been shown that to fracture your hip, you have to fall laterally. You could fall straight on your face, you'll never fracture your hip. You could fall on your back and you won't fracture your hip. You have to fall laterally. Therefore, in ladies like this, I say ladies because they're mostly ladies, in ladies like this, in perhaps some of your grandmothers or some of your mothers or some of your friends, if you have this situation and you want to really be efficacious in preventing a hip fracture, pad the hips. Pad the hips. There are commercially available undergarments that have hip padding in them. If you can't find them because they're difficult to find, use shoulder pads. Use shoulder pads in the hips so that if this patient does fall and falls laterally, there won't be a hip fracture. By the way, this is not just theoretical, it's actual. It's actually been shown that hip padding prevents fracturing of the hips. I think that, if I'm correct, is the last slide. I'll stop for questions, and we'll be early for for dinner, so we'll call in for pizza. I'm going to stop here and thanks. Yes, sir. Right. Well, it's a very good question, and it's very important. You see, if that same lady has had a hysterectomy, if that same lady has had a tubes tied, if that lady promises you, not orally but by her behavior, that she's not going to get pregnant, certainly she's a great candidate for one of these drugs with calcium and vitamin D. The problem is, as I mentioned to you, if you give her one of these bisphosphonates, and then 10 years down the line, if she becomes pregnant and the baby is born with defects, particularly bone defects, you're in deep trouble. So the recommendation now for all the bisphosphonates, no matter what they are, is that they not be used if the potential for pregnancy exists. What I would do with your lady is I probably would put her on calcium, vitamin D, and a very vigorous, remember she's only 27, you said, so she really hasn't even peaked as far as bone mass goes. That's the kind of lady that I would be interested in sending for physical therapy, making her really strong, because she still has those cross struts, those striations in her bone, and you can still make those stronger. And I would present, I mean, you know, it all depends on what kind of patient you're dealing with. If you're dealing with a couch potato, but if you're dealing with someone who realizes that the only thing you're trying to do is help her, and you say, look, here's the bottom line, I can't give you these drugs because I'm afraid that somewhere down the line you're going to get pregnant, but here's what we can do. And say, you haven't yet finished with maximum bone growth. What I would do if I were you is go to the gym every single day for an hour. I would do weight resisting exercise. I would lift weights. I'd lift them at home. I would do as much physical stuff as possible. Now that answer is different if the lady is, or the patient is 55 or 60 years old. Yes, Dr. Vanderwall. Do you all know Dr. Vanderwall? Dr. Vanderwall is a physiatrist extraordinaire who we have the pleasure of working with in our office. No bless. Everybody knows you. Naive.
I have a question.
Sure.
I've seen a number of patients, not a number, but a few patients, men, in their 40s
Oh.
who are osteoporotic.
So
How
thank
frequent
you.
do you see?
Thank you so much for reminding me. This was not planned, but I really neglected, because I spent all my time talking about women, I neglected to tell you that osteoporosis does occur in men, and everything I said about women is true about men, and although the incidence was originally given as 10 to 1 female to male, it really is more. It's probably 4 to 1. And we have many men who are on Actonel now. Sure, absolutely.
Interestingly,
Yeah.
2 of the patients that I had did not fit the typical criteria for women. They were Hispanic or African American,
Right.
young 40s,
Right.
relatively active men. And, is there a genetic component?
There's an important genetic component, but there's another thing that you should measure. Measure their testosterone. Many men who have low testosterone will be osteoporotic. It's a very important point that you raise. And by the way, they won't tell you about the symptoms of low testosterone. And the symptoms of low testosterone are primarily, but not exclusively, sexual. You can't get an erection. But if there's serum testosterone, we're going to do a bone density, absolutely sure. And with men, at least, you don't have the same problem in treating them with bisphosphonates. Dr. Boskin.
Is there any way to determine if these elderly women are osteoporotic, if they fracture their hip first and they fall, or they lost their balance or vestibular problem they have, and they fell and broke their hip before? Is there any way to determine that?
What do you mean, what came first?
How do you, yeah, what came first?
Well, while they're in the air, nothing's broken.
Yes, but the doctor was examining them,
Right.
breaking their rib.
Right.
See,
Okay.
I
You could break.
I can never determine
Yeah.
if they broke their hip. Say, my mother fell and had a broken hip.
Right. And the first thing you say is not my fault, right?
Did they fall and break their hip?
Right.
Or did the hip fracture and that's why they fell?
No. What they did, again, remember I said about the hip padding?
Yeah.
I promise you, and you can demonstrate it for us if you want. If you fall forward on your face, you won't break your hip. If you fall backwards on your backside, you won't break it. If you fall laterally, you will. So it has a great deal has to do with how you fall. If you're saying
ask them,
right.
how did your mother fall?
Of course. Of course. I mean, also, you know.
I found her on the floor.
Right.
You gotta say, Ma, how did you fall?
Right.
Did you fall sideways?
Listen, if she is lying with her, in a typical position,
Why
the
did they take a
lady.
picture of them?
No, you don't
Turn
think.
over.
But listen, if she is lying in a typical position with a hip, that looks like it's a part of a rag doll, she fell sideways. If, on the other hand, she's lying with her legs and they're equal, and there's no fracture, I mean, you know what a hip fracture.
We gotta do a study.
You don't have to do it, you got to just look at her. Look at her and say, Mama, move your hip, right? Okay, if she picks up her hip, it's not broken.
Shelley, can I just add to that?
Thank you.
Very interesting question, because I worked with the geriatric rehab population for a number of years, and a lot of patients had hip fractures. Some of them would give a history of before falling, they would hear a pop.
Yes.
In other words, they twisted and the torsion, and they were so fragile and so osteoporotic that they broke the hip before they even
The
fell.
pop test.
Exactly.
Blau's abandonment pop test.
Now, he's trying to walk up that. It's good, I like that. Yes. Oh, yeah, Lorraine, oh, yes.
For a woman in her 20s, to 30s, what would you recommend so that she doesn't have to go through all of this?
So that she doesn't have to go through all of this?
Right.
Well, I'm going to tell you something, and you're going to think that I'm being funny, but I'm not. In the Orthodox Jewish religion, the prayer of the morning, and stop me if I'm wrong, okay. Well, tell her the first prayer that an Orthodox Jew says in the morning. Thank God I'm not a woman. So the first thing is this must have been recognized 6,000 years ago. What I would do if I was your age, and what I should do to prevent a fracture, osteoporosis. Well, first of all, like I said to you before, you have a low, unless you smoke, which I know you don't, okay? Unless you drink a lot, which I know you don't. Unless you take any of the medications, which I know you're not. I would exercise. I mean, exercise has become so important in living that between the ages of 15 and 30, if I had it all to do over again, I would be in the gym every single day. Instead of playing cards with you.
What about increasing
Thank you. Jerry, thank you very much. Because I mentioned Oscal and I mentioned calcium supplementation, but the best way to really get it is with foods. Sure, absolutely. You can, and nutritionists do this all the time, and you can easily plan out a program without calcium supplementation in the form of Oscal that includes foods. Everything green has got calcium. Baked potato skins, yes sir.
What I was curious about when you said foods, I know they recommend Tums as a good source of
Yeah, Tums is calcium carbonate.
Does it get absorbed, or are you better off with some of the...
Calcium carbonate is better than calcium chloride. As a matter of fact, Tums are well absorbed. When I say well absorbed, understand that by well absorbed, I'm talking about very small percentages. Again, you can't prevent fracture. That's whenever I tell the truth. You can't prevent fractures by just taking Tums. The equivalent, each Tum has 200 milligrams of calcium. The Tums extra large are 400. So you would have to take one Tums 3 times a day. Sure, that's fine, but remember now you need the vitamin D. How are you going to do the vitamin D? So you would have to take one Tums 3 times a day, and now an exogenous source of vitamin D. The only reason that I like, and it's just convenience for the patient, that I like a preparation that has calcium and vitamin D, is it's twice a day. And by the way, I'm kind of glad you brought that question up. You can't take Oscal 2 in the morning and have your total calcium supplementation. It doesn't work that way because it's poorly absorbed. So, yeah, Tums is great. It's a good calcium carbonate source. You then would have to add vitamin D. I think that Oscal with vitamin D is probably Tums with vitamin D. Exactly. But that's a good question. Yes?
If someone's taking the medication,
Right.
is there, first of all, can they take it for many years without any
Well,
problems?
Gloria, that's a good question also. I mean, so far the long-term studies have only been probably with Fosamax, probably, I would guess 5 years. With Actonel, they've been 3. Well, I reported here is 3, by now they're probably up to 4. So far the answer to that is yes. By the way, I have to also hasten to add that any of these bisphosphonates are not metabolized. They're excreted in the urine totally as presented. So there really is no, except for GI and except for problems I showed you, you don't have to worry about cumulative dose.
And the other thing is with GI, by the time if a patient has a symptom, is it already a lot of damage has been done?
No, you've had agita, you can have agita, no. As a matter of fact, it's kind of, I mean, there are two things that you should know. The first thing is that most patients who have GI bleeds, as a matter of fact, I just saw the data this morning. Where did I see the data? I saw the data this morning. 80% of them are asymptomatic. That's the first point. The second thing is that you can have an extensive, and this was the last patient that I saw today. This lady was taking aspirin ad lib, had a GI bleed, was gastroscoped, found to have a gastric ulcer from the aspirin. She was put on one of the Prilosec drugs. It healed, and I put her today, as we speak, on Actonol once a week. So it's not forever. Those things heal. Ralph?
In people that are very high risk, is it possible to give the medication before osteoporosis develops?
Well, that's also a very astute question, Ralph. That's exactly what they want to do now. As a matter of fact, that's exactly what they're suggesting, that people who have high risk for osteoporosis be given, if you will, prophylactic medication. Absolutely. But remember something. That's a matter of choice. I'm happy to tell you that my wife had a bone density, and it was fantastic because when she was a kid, she was a dancer and she was physically active and all that stuff. So her bone density was marvelous. She said to me, "Should I take Actonol?" And I said, "No. Let's just repeat it next year, repeat it next year." And the reason for that is, although I showed you an example of high risk that didn't have osteoporosis. Remember, not everybody gets osteoporosis, even with high risk people. So if you are genetically programmed, if you will, not to develop osteoporosis, why take a medication that you don't need? So the key is, I mean, the tip-off is, the index is a bone density. If your bone density is abnormal, you don't have to be short with a pot belly, take it. If your bone density is normal, repeat it. And remember that it's important that even though Medicare pays for a bone density every 2 years, we do them every year. I mean, we tell the patients we really want them on a yearly basis. I treat, as some of you know, I treat most of my patients, I treat my own family. My wife will have another bone density next year, even though she has no evidence of osteoporosis. Now, her T-score is perfectly normal. I'll repeat it in a year. If at that time, if for instance, now it's perfectly normal, and next year it's gone to minus 1.5, and it's still not full-blown osteoporosis, well, that's a different story. But she may, and I hope she remains at 0 forever, and will not require me. Okay, if there are no other questions, I would ask Kathy to tell them to bring the stakes in. And thank you very much.
Thank you.
Bring on the dancing girls and the snake. Okay. Well, we'll see how it comes. You have my address?
No, sir,
Okay,
but I would like to get it.
Kathy, let me give you my address.
Beautiful.
And let me just get back my slides.
Yes, sir. That's what I'm doing. You gotta get to that little break.
Yeah, that's right.
That was a great talk.
Yeah. Oh, 4 bony bed. Yeah, sure. Remember, this wasn't... I'm sorry?
He was peeing his pants.
Why?
I wonder if that's going to come out on the videotape. You
Why?
little side jokes. Why his pants?
Oh, well, I'm a funny guy.
Good.
Oh, wait,
Good. I wish all the doctors were like that.
Right.
Some of them are very boring.
Well, I'm sure. Here, let me hit.